Well, good morning, everyone, and greetings from the United States. As you can see, I have a very ostentatious office here, but I appreciate Chris and David and everyone for asking me to chair this panel today. I'm an otolaryngologist, head and neck surgeon here in Boston, Massachusetts. I got up bright and early this morning at about 10 of 4. Have my carb loading here. I have my coffee, my diet soda, and a little more caffeine loading. So I'm ready to roll today. So this is a very interesting panel, and I do want to share some slides with you early on. And let me see if I can get that going here. So today we are going to, David, can you see my slides okay?
Perfect. Yes, I can see them.
Excellent. So first I want to introduce our panelists today. We have Dr. Ali Khurram, from whom we heard yesterday. Dr. Khurram is the senior clinical lecturer and consultant pathologist at the University of Sheffield. He is involved in the diagnosis of head and neck cancers on a daily basis. He's the clinical lead for oral pathology diagnostic services, covering most of South Yorkshire or Yorkshire. I'm going to make a pass at that one. He previously worked as a junior doctor on oral and maxillofacial surgery and is firsthand aware of the devastating nature of these cancers. Additionally, today, we have Dr. Lauren V. Wood. Dr. Wood joined PDS Biotech as Chief Medical Officer in February 2019. She has an overall responsibility for clinical development of the novel immune-activating Versamune platform product pipeline targeting HPV-related pre-cancer and advanced cancers, as well as a broad spectrum of solid tumors. She has a 30-year extensive clinical research experience at the National Institutes of Health, and Dr. Wood was recently the clinical director of the vaccine branch, Center for Cancer Research, the National Cancer Institute, and oversaw translational development of immune-based therapies for cancer and HIV infection, and co-inventor of 2 patented therapeutic cancer vaccine platforms targeting TARP and HER tumor antigens, so TARP and HER. So I want to just run through very quickly before I turn this over to my esteemed panelists here, a few thoughts I had about drug therapy in cancer. So today we're going to talk about perspectives on drug therapy for head and neck cancer. Let me put things in perspective. I was in medical school 1984 to 1988 and then residency thereafter. And at that time, there were some oncologic doctrines. Breast cancer was still a surgical disease, sometimes supplemented by radiation and chemotherapy. And that was particularly during my medical school years. Chemotherapy for head and neck was considered just for recurrent and curable disease, really as a means to prolong life and not necessarily quality years of life. Immunotherapy and biologic therapy really were not even a consideration. And then it all happened. The VA cooperative study, affectionately known as Greg Wolf's study, was published in the New England Journal of Medicine in 1991. Induction chemotherapy plus radiation compared with surgery plus radiation in patients with advanced laryngeal cancer. And this is the front page of this article. This was truly groundbreaking. This was the article that showed us that we could potentially save the larynx in people with head and neck cancer, with laryngeal cancer, and be able to treat them with chemoradiation, with 65% of these patients saving their larynges. Some of them did have to go on and have their larynx out, with equal cure rates. And this really opened the door for us because now we routinely treat multiple head and neck cancers with chemoradiation protocols, reserving surgery just for residual or recurrent disease. It's not to downplay the side effects of chemoradiation, particularly radiation, but it avoids devastating surgery in many cases. And now there remains a role for surgery as a primary or sole treatment. Early basic tongue cancers I treat with the robot, as well as tonsil cancers, and anterior tongue surgery remains the standard for small tongue cancers. HPV positive cancers in particular have really been amenable to chemotherapy, chemo-RT, I should say, versus prior treatment where we did radical surgery and post-operative radiation therapy. And in terms of chemotherapy, these are some of the usual agents we've seen over the years. And I'm going to ask my panelists to really comment on these in terms of these are the usual chemotherapy agents, bleomycin, Taxotere, and you can see the list here and some protocols such as TPF, Taxotere, cisplatin, and fluorouracil. But then there is immunotherapy, much more recent in terms of Erbitux, Keytruda, and Opdivo. And some of these medications, Erbitux, Keytruda, we've also seen in treatment of rheumatoid arthritis and some of the autoimmune diseases.
Arthur, just
Yes,
to
sir.
say, you have an extra panel member that was added at short notice, so you may not.
That's Ben, right?
Ben has joined the show.
Hey, Ben, how are you?
Hey, Arthur. Good to see you, sir.
Ben's such a friend. I just assumed he was just interested in hearing my panel and wanted to be there on first hand. So
well, we always catch up at some point, so it's good to see you, sir.
Usually through Facebook. Good to see you, my friend. I'm curious about one thing. I have to ask David something. So there's a couple of towns I'd hope to see in Wales. One is MWNT is the name of one city, and PLWMP is the name of another one. I have to admit, the names of your places in Wales are pretty daunting. So we'll leave it at that. Anyway,
I'll teach you later.
Yeah, I'm very frightened. So I'm going to turn it over to my panelists. They both have some presentations to give, and then we're really going to open this up quickly to questions and go from there. We have Lauren. Lauren, you're on mute right now, and you can unmute. And we have Ali, and I'm going to ask who would like to go first. I know you both had slides prepared.
Thanks, Arthur. I mean, Lauren's presentation is going to be very specific and sort of targeted to this, the drugs and the details of them. So I thought I can just start by setting the scene. Yesterday during the conversations, one thing that was obvious is that we become used to using a lot of terminology in our day-to-day life as clinicians and professionals, things that patients may not be aware of, so things that are obvious to us. So I just thought I'll just go through some very basic slides explaining some of the things that we might be talking about, and then Lauren can hopefully take from there. So let me just share my presentation. Can you see the slides?
Yes.
So I just thought I'll set the scene. Basically, you'd probably hear the word biomarker or markers a lot, and if you're not familiar with the term or what it means, it's basically a molecule that's present within the body. It can be within the tissue or any of the bodily fluids, and that can indicate either a normal or abnormal process, or it can be specific to a condition. In this case, of course, we are talking about head and neck cancer. And these biomarkers can be used to either diagnose a specific condition, but we can also use them to monitor or predict how cancer may respond to certain treatments, or how they might respond to treatment that's already been given. And most of you know what chemotherapy is, but I just thought I'll just go through the basics. Basically, using drugs to kill cells, and it works by trying to stop or slow down the cancer cells. It tries to stop them from growing, from dividing, and also making more cells. Cool. Because cancer cells inherently, the main difference between cancer and normal cells is that normal cells have a limited life. So they start off their life and they eventually die, and they're replaced by other normal cells. Whereas cancer cells are immortal, so they don't die. So these drugs, or chemotherapy drugs, are actually poisonous chemicals. And these poisons can actually target these cancer cells and kill them. But of course, it's difficult for them to differentiate between cancer cells and normal cells. So as a result, you also get damage to the normal cells, which can lead to side effects. And ideally, the drug that you want is something that can kill a lot more cancer cells and causes as little damage to normal cells as possible. And these drugs, or the cycles that we use in terms of how many times the patient may have to go for chemotherapy, or the doses, etc., might be different for different patients, and of course, different in different types of head and neck cancer as well. And again, these drugs like cisplatin, they can be used alone, or they can be used in combination with other medications. There's another type of therapy which is called targeted therapy, and in targeted therapy, actually, we use antibodies to target specific genes or specific proteins. Basically, think of these as antennas on the surface of cancer cells. So we're actually going to target those to stop the cancer cells from talking to other cells and slow them down. Okay, so it works on the principle of an antigen-antibody reaction. In this case, we are thinking about, for example, the most common one that we use is these epidermal growth factor receptor inhibitors. Okay, so we try to look for their expression, whether they're present on the cancer cells or not. Okay, so if this was the antigen, which is the EGFR, and this is the antibody that we're going to administer against it, this antibody is going to go and stick itself to the EGFR, okay, which will stop it from signaling because it's already stuck to something, which means it can't talk to anything else. And that actually helps to reduce the cancer growth and spread. And this also causes less damage to healthy cells. But of course, not all tumors have the same targets, and special tests may be needed to identify what targets are present and how much they are expressed. Here's an example of within head and neck cancers, how it can be variable, EGFR expression. So yesterday I was telling you about tests that the pathologist can do to be sort of guide or help your treatment. So in some cases, it can be negative, it can be moderately positive. So some cells are positive, some are negative. So the brown color here indicates a positive reaction, or it can be strong positive. But the latest and the sort of very exciting development is immunotherapy, which boosts the natural defense in the body to fight cancers. So it can be your body's own cells, or it can be other materials or drugs that can actually enhance that response to fight cancers. And the most common ones that are being used or have been licensed to are PD-L1 inhibitors. That's programmed death ligand 1. And basically, it reprograms your immune cells, your white blood cells, to actually identify the cancer cells and fight them. And have shown a lot of promise, particularly in head and neck cancers that are recurrent, i.e. that keep coming back, or are metastatic that are spread to the neck and other parts of the body. However, you can get reactions related to them. And they've shown quite a lot of promise in the trials that have happened so far, quite good success. Both of these drugs, Pembro, which is a short of this, can be used on its own, but both can be used alone or in combination with other drugs. And the pathologist again comes in sort of helping whether it's cancer is suitable or a patient is suitable to receive certain treatment. And we do that by giving score, okay, a combined positive score. And the combined positive score basically means how many of the cells express this PD-1. Okay, so how many of the cells are positive? So for that brown bit of color that I was showing you, you divide that by the total number of alive tumor cells and then multiply it by 100. And if the score is less than 1, then that patient is not suitable for the immunotherapy. But if it's greater than 1, they can receive the treatment. But the best results are seen in patients who have got a score of greater than 20. Here is an example of a head and neck cancer. The sort of rounded ball-like structures that you're seeing here are the cancer cells. These are the immune cells. Here is a special test that we've done for PD-L1. And there's no brown in it. You can see it's all blue. There's no brown in it. Okay, so this will be a CPS of less than 1, which means this patient is not suitable to receive immunotherapy. Here's another cancer. In this, you can see these cells are the cancer cells, okay, the darker pink cells. And then we do the PD-L1 staining on these. You can see that almost all the cells have got this sort of brown membrane or that reaction around them. So this would be quite a high CPS or PD-L1 score, which means this patient would benefit from immunotherapy. And very briefly, just mention combined therapies. A lot of the head and neck cancer therapies are combined, whether with immunotherapy or different types of chemotherapy, finding the best treatment, causing the minimal amount of damage and maintaining the quality of life. And some recent developments are, of course, things like gene therapy, which can use viruses to actually change the genetic makeup or the code to target or stop cancers. Another avenue is photodynamic therapy. And in that, you actually introduce a medication which is called a photosensitizer. That drug is taken up by the patient, and then the laser is actually targeted. And those cells that have actually taken that drug up will actually be more receptive or more responsive to the treatment, which means you limit the damage to the normal cells. But the long-term effects of this are still being studied. And I think with that, I'm done. Thank you very much.
Arthur, before we move on, Ali, can I just say thank you very much? I've seen a few of your presentations over the years now, and every time I learn something new, but it's in a language that I can understand as a non-medical professional. So thank you. Great presentation.
Great. Well done. Thank you so much. Lots of interesting information there and very exciting. And certainly, as Chris had sent out, if you have questions, please put it in the Q&A section. And I think there'll be a lot of good questions just on that presentation alone. I'd like to turn things over now to Dr. Lauren Wood to hear her side of these interesting topics in terms of new drug therapies for head and neck cancer. Dr. Wood?
Good morning, everyone, and thank you so much for having me, Chris. Ali, thank you for that incredible overview. That's straightforward in terms of breaking down the complexities of cancer treatment. Arthur, thank you for being a host. Just to highlight to everybody, I have my Swallows mug with double bagged Harrods English Breakfast number 14, which is my favorite tea. And I figure, just like people walk into Starbucks and say, give me a 1 shot, 2 shot, triple shot. Well, it's a double bag morning because I forgot that the time went backwards in the UK. So I was up an hour earlier thinking that we were going to start at 4 a.m., but it's all good. So let me go ahead and share my screen. Okay. All right, can everyone see my screen? Now I'm going to go into presentation mode. Is everyone able to see it? I hope.
Yes.
Oh, wonderful. Thank you so much. So I really do appreciate the opportunity to introduce to you a novel type of immunotherapy to treat HPV-related cancers and specifically head and neck cancer. So a little bit about our company, PDS Biotechnology. We are a clinical stage immuno-oncology company that's based in Florham Park, New Jersey. Drug development of our product started back in 2007, based on the discovery that certain lipid, actually fat, particles had immune stimulating properties and stimulated the immune system. And this was discovered at the University of Pittsburgh School of Medicine. Our focus is developing novel platforms that basically activate T cells, which are part of the body's immune system, different from antibodies that Ali highlighted during his presentation. So I'll give you a little bit more information about that. When delivered, these disease-related proteins known as antigens, Versamune is designed to train the immune system to better attack and destroy cancer or even infected cells. Our Versamune-based product, PDS-0101, is being developed specifically to treat HPV-related cancers. So, as Ali mentioned, we have come such a long way. It's incredible now that we have a fourth mainstay to cancer treatment. As Arthur highlighted, in the early days, we both went to medical school at the same time, 84 to 88. And we know that we now have, in addition to surgery and chemotherapy and radiation therapy, we have immunotherapy, which has become the fourth cornerstone of cancer treatment. Immunotherapy can be very, very impressive when it works in patients. As Ali highlighted, we really need to sometimes do diagnostic studies on the patient's tumor tissue to know whether or not they're likely to respond to the immunotherapy. But one of the things that we found is that even when the responses are very dramatic and significant, the problem is that they only benefit a minority of patients, usually only about 20% of patients on average. And one of the things that we've discovered is that one of the main limitations is patients who seem to respond to immunotherapy like Keytruda, like Opdivo, and other checkpoint inhibitors. These are patients that already have evidence that their immune systems are trying to attack and get into their tumors. And the problem is that if you take the brakes off the immune system, which is what we do with checkpoint inhibitors, but you have no gas in the tank, which is T cells to attack that tumor, you don't really have the clinical benefit. And that's what our platform is about. It's about stimulating a patient's immune system to make their own CD8 killer T cells within their body and then attack the tumor. So we've known and now we've been able to document that Versamune can generate a strong T cell memory response, which contributes to long-lasting efficacy. We know that it does it without generating systemic toxicity because it is a therapeutic cancer vaccine, and I'll get into that in a little bit more detail. And we also know that the Versamune platform is pretty versatile because it's been shown to be effective on its own, as well as in combination with other kinds of immunotherapy. So this is a picture of the Versamune platform. What I have here that looks like a dissected Pac-Man is actually a Versamune nanoparticle. I mentioned that it is a lipid nanoparticle. So a lipid is just a fat. And it turns out that this nanoparticle has a positive charge to it. And here, the green part of the Pac-Man represents the water-soluble and positively charged portion of the fat molecule, which is down here at the bottom. And you can kind of see this long chain, and that represents fatty insoluble chains. And so when you expose these lipids in water, they actually form these nanoparticles, and they're spherical nanoparticles. And importantly, we actually engineer them and size them so that these particles are about the same size as viruses. And because they're the same size as viruses, when we introduce them into the body, cells of the immune system think that maybe they're seeing a virus, and they gobble up these nanoparticles. So there are a couple of unique properties. I already told you about the fact that they're positively charged, which means they actually fuse with cells of the immune system very effectively, and they form these nanoparticles. The other thing is that we know they're sized to mimic viruses so that they're taken up by the cells of the immune system. I'm going to introduce two major immune cells to everybody. One is the dendritic cell. The dendritic cell is a cell that we call an antigen presenting cell, and it's basically the light switch of the immune system. Anytime there's any kind of foreign invader, or even maybe dying cells that are old, which is a normal process that happens in our body, dendritic cells recognize either dead or dying cells. They recognize viruses and bacteria, and they take up those foreign pathogens, chew them up into small little pieces, and present those pieces on the surface of the cell. But basically, they broadcast to the entire immune system that, hey, warning signal, we need to generate an immune response, and it allows activation of other cells of the immune system. When these dendritic cells get activated, they actually migrate to an individual's lymph nodes, either in the neck, sometimes under the arm. And we know that with Versamune, those dendritic cells get activated, they get revved up to present whatever is foreign, and they actually stay there and present whatever it is the immune system is supposed to recognize and get rid of to T cells. These T cells then get activated, and they get armed, and they go and they track to the tumors, and they kill the tumors. Finally, one of the things that Versamune does is that it triggers a very important immune system protein. I mean, I'm an immunologist who's treated both patients with cancer as well as HIV infection, because it's all about harnessing the immune system to fight disease. And the immune system is this vast, infinite universe. But importantly, when things are wrong in the universe, there are very, very important proteins that result in making sure that the immune system gets on alert and knows that there's time that something needs to be done. So in a nutshell, this kind of highlights exactly what Versamune does. On the left-hand side of the slide, excuse the background, is the Versamune with an antigen. The Versamune is the green particles, the antigen is in blue, and we deliver it under the skin. It then increases, it's taken up by the dendritic cells, and in the middle, these dendritic cells with their long-like projections process the antigen, break it up and chew it into little pieces in the lymph nodes, and then they stimulate T cells of the immune system. The T cells are represented as the red T cells, which is a CD4 T cell. It's kind of like the captain of the immune system or the quarterback of the immune system football team. And the blue cells are, CD8 T cells are in red here, and CD4 T cells are blue. So the blue cells are the helper cells, and the CD8 T cells are the killer cells. My apologies. But the key thing is that both of these types of cells get activated. And it's very important that once these cells are activated, they're then armed. It's like training special ops forces to recognize what the cancer enemy looks like and then stimulate them to go directly to the tumor site on the right-hand side of the slide, attack the tumor, and then destroy the tumor. So while Ali had demonstrated that antibodies can bind to antigens, okay, that are on the tumor, this is actually training T cells to go and recognize the tumor and destroy it. This is a little bit scientific, but there's two takeaways here. On the left-hand side of the slide is just an example of how we train this army and how we train large numbers of cells. And the cells that we train are really armed and potent. They're not shooting blanks. They're actually armed with great, what we call immune bullets, cytokines that are able to then target and kill tumor cells. On the left-hand side, you see just a regular adjuvant, which is given with a protein to stimulate the immune system. The antigen that we're using here is different from the one in PDS0101, but it's representative. And you can see there's very little volume of cells that are trained. The middle is with a different kind of antigen adjuvant that's really engineered to be super potent and have 4 different kinds of elements to really stimulate and train these T cells. And again, you get a little bit more of a bump, but not much. But in the far right, you can see with the tall green vertical bar, we get lots of trained T cell soldiers. And more importantly, based on the dark green bar, we know that many of these T cell soldiers really have multiple weapons, multiple cytokines to kill and attack tumor cells. On the right-hand side is a reflection in a mouse model where we give a mouse basically a tumor that grows unchecked. And you can see that if you don't treat these mice with HPV-related tumors, in the gray line, it just grows like crazy. If we deliver the tumor antigen HPV-16, because we know that HPV-16 is expressed on these tumor cells, if we give it alone, the tumor continues to grow unchecked. If you deliver the antigen for HPV-16 with one of the typical adjuvants, you do see some slowing of tumor growth, and that's the blue line. What's pretty remarkable and what stimulated us to want to try this new therapy and study it in patients is the fact that if you deliver these HPV-16 antigens, small pieces of protein with Versamune, and you give a single dose, you can see in green that the tumors are completely eradicated. The tumors totally regress and go away. What's more important, though, is that if we come back and we challenge these mice with tumors, the bottom line is that the tumors don't grow back, which lets us know that the immune system now remembers and recognizes what the enemy is like. And that's one of the things that is really, really important for us to try and do, because we not only want to shrink and kill and cause the tumors to die, but we want the immune system to remember what the enemy looks like so that if it ever rears its ugly head or starts to, that the immune system is equipped to eliminate it. So
sorry to interrupt, Lauren. Would it be possible to make the slides bigger? Some people have commented they can't see it full screen.
Okay, it is full screen on mine. So
that's fine.
I thought I was doing it in projection mode. Hold on, let me try one thing. If I do it this way, can people see it better?
Yeah, it's bigger and better.
Okay, all right. sorry, my sincere apologies. I couldn't see your chat. This is now at like 236%. So is this a little bit better for everybody? Okay. Okay. My apologies. Thank you, Ali, for bringing that to my attention. So this is just highlights the fact that Versamune is engineered for simplicity and ease of administration. We deliver it subcutaneously. All right. Just an injection under the skin. We deliver it under the skin because that's where those dendritic cells are. The skin is loaded with dendritic cells. And because of its mechanism of action, we don't have to deliver it into the tumor. You may have heard of some therapies that are investigational that it directly inject chemotherapy or immune-based therapies into the tumor, or it doesn't have to be delivered into the lymph nodes because we know that those dendritic cells get activated and just migrate right to the lymph nodes. It's a 2-vial formulation. We mix it just before delivery. The lipids are in the blue container. The peptide antigens for HPV-16 are in the white container. And then when we mix them together, it's early in the morning and most people don't eat spaghetti and meatballs for breakfast. But in the middle is what we call an electron micrograph. It's a very detailed look at what the mixture looks like. And you can see the meatballs those are the Versamune lipid nanoparticles, and the little strings are the HPV antigens that basically the dendritic cells see and gobble up and eat as a meal and get activated. And again, it's delivered under the skin. We did a phase 1 study in women, actually, who had not HPV-related cancer, but they had an HPV-related precancer condition called CIN, or cervical intraepithelial neoplasia. And this was done in women with low-grade CIN and multiple high-risk types of HPV infection. We studied 3 different doses of the Versamune. It was safe. It was well tolerated. There were no dose-limiting toxicities. The main adverse reaction, as one might expect, was the fact that you got local injection site reactions because you're getting a vaccine. It's a cancer vaccine. We also saw that in women who had gotten this vaccine, 6 out of 10 women had their precancerous lesions actually go away within 1 to 3 months after receiving the series of treatments. This just highlights the fact that we're trying to help the immune system recognize what the enemy looks like. Because I'm not in PowerPoint mode, there's no animation, but the green lines show what the immune system is recognizing in terms of how much the immune system is recognizing of the enemy in green. And then in dark navy blue is following delivery of PDS0101. And we can see that the immune system responds with a greatly increased number of cells at all the doses tested, low and medium on the left, as well as high. And that's what we want to do. We really want to be able to stimulate the immune system to help recognize the enemy. I'm going to go through this information really quick, but this is some data that was recently presented by Dr. Julia Strauss at the National Cancer Institute, who's leading a trial of PDS0101 in combination with 2 other investigational immunotherapies in patients who have advanced HPV-related cancers. And the reason why this trial was important to us is this is one of the first trials that are helping us confirm the activity of PDS0101 in patients with advanced cancer. So we can see that in 25 patients that had advanced cancer, this was reported at the 2021 June ASCO meeting, we have head and neck cancer patients represented significantly, 24% of the patients, in addition to patients with anal cancer, cervical cancer, vulvar vaginal cancer. All of these are HPV-related cancers. The takeaway is that all of these patients were heavily treatment experienced. 100% of them had received prior chemotherapy. 95% of them had had prior radiotherapy, and over half of them had had checkpoint inhibitor therapy and failed that as well. So this slide highlights what the results are in patients who are naive to checkpoint inhibitors, meaning they've never received that immunotherapy that Ali was highlighting. And we can see that when given the triple combination, a very large percent, 86%, 5 out of 6 patients actually had evidence of objective response and shrinkage of their tumor. This is compared to usually what we see with checkpoint inhibitors alone, around 12 to 24%. So again, we're seeking to move the needle with combination therapy so that more patients will benefit from the combination. In patients who were checkpoint refractory, we also saw some very significant reductions in tumor. So these are patients who've already had immunotherapy. They progressed on immunotherapy, but we're coming back around and we're giving them immunotherapy again with a checkpoint inhibitor plus PDS0101. The two investigational immunotherapies that we're giving are an investigational immunotherapy called bintrafusp alpha. It's a mouthful, that's why we say bintra, and another tumor targeting cytokine called IL-12. Again, even in patients that were checkpoint refractory, we saw a significant reduction in tumor, about 58% of patients showing some decline in their tumors. And on average, it's really only about 5 to 12% of patients that respond in that setting. The key thing that I want to highlight in addition to these responses is that there was also very good evidence that we were seeing a benefit as it relates to survival preliminarily. The median time that patients had been followed up at the time these results were presented was about 8 months, and 100% of the checkpoint naive patients were surviving at a median of 8 months. And historically, it averages between 7 and 11 months. In patients who were checkpoint refractory, we saw that 83% of them were still alive at eight months of follow-up. And this is a significant difference because the historical survival is 3 to 4 months. So the goal is hopefully we can shrink the tumors, but also hopefully we can better help the immune system to control disease so that patients can live longer. Finally, Ali mentioned that we can use antibodies to specifically target a protein that is present on the cancer and tumor cells. We're just doing that with T cells. And this shows that in patients who have HPV-16 on their tumors, there was a very dramatic reduction in tumors, 63%. That means that they have the target of the T cell that the T cell is armed to recognize and kill. But in the patients on the bottom half of the slide that did not have HPV-16, you really did not see any evidence of tumor shrinkage. So again, it's important to have that. A lot of information here. The takeaway is that PDS0101 was safe with these two other agents and really did not increase the toxicity of the combination or contribute to any new toxicities that was previously unknown and associated with the other two agents in the regimen. So my final closeout is going to talk about our study of Versatile-002, which is PDS0101 in patients with advanced recurrent metastatic head and neck cancer. Again, Ali had mentioned that we know that we can give Keytruda, which is pembrolizumab, either alone if there is sufficient expression in the tumor of that PD-L1 ligand, or it can be given in combination with chemotherapy. This specific investigational trial is looking at PDS0101 in combination with Keytruda. This just highlights here that Versamune works with multiple tumor antigens. On the right-hand side of the slide, more mouse data that just shows if you give a Versamune-based vaccine plus a checkpoint inhibitor, you see a much greater reduction of tumor growth, which is the right-hand slide and reflected in the green line. You see the most dramatic shrinkage of tumor when you give two agents together. And that's why in advanced recurrent metastatic disease, we're really looking at combinations. So just like the NCI study, this study is looking at PDS0101, but it's only with one other agent, which is Keytruda, which is licensed for this treatment indication in head and neck cancer. And we're giving it in combination. Together, we give both agents in 4 cycles up front. And then patients continue to receive standard of care Keytruda every 3 weeks. And then we give a booster dose of PDS0101 about 6 months after the 4th dose. And then patients go on to continue Keytruda until there is either disease progression or they develop intolerance to therapy. This is a 2-stage design. It's 2 stages because we're looking at naive patients and refractory patients separately, although we're looking at them in the same way. And the reason for doing that is that we know that it actually may be much harder to treat patients who have already been treated with checkpoint inhibitors. So we have 2 groups of patients. The top group is those who are naive to checkpoint inhibitors. The bottom group is those who are refractory to checkpoint inhibitors. We have a lead-in safety cohort of 12 patients. And just last month, actually in September, our DMC reviewed the fact that the combination was safe. There were no unexpected toxicities related to either PDS0101 or to pembrolizumab. The main adverse event was local injection site reactions. And so with each stage, we recruit patients that are naive as well as refractory and are looking for a certain level of response before we proceed on to the next stage of enrollment. So this just highlights that there are a lot of approaches to immune therapy, and PDS0101 and Versamune-based platforms are pretty different and pretty novel. They do more than just regular adjuvants designed to stimulate the immune system or cytokines. There's other technologies, as Ali mentioned, where we could deliver viruses. Usually those have to be delivered into the tumor, but sometimes they can be delivered intravenously. We know that checkpoint inhibitors do a phenomenal job of kind of unmasking the enemy and taking the brakes off the immune system. And we can get incredible T cells that go in and attack tumors. Some people have heard of CAR T cells, which have been very successful in malignancies like leukemia, where we take a patient's own cells, grow them outside of the body, kind of expand the army and train them in the lab, and then infuse those T cells back into the body. But they don't really well. It's kind of been disappointing in terms of their activity in solid tumors like head and neck cancer. And so Versamune is able to do a lot of these things to train the immune system, to raise up that army of T cells, but it's in the body to then recognize and go attack tumor. And we've got several other studies that are looking at PDS0101 in advanced cervical cancer, as well as other antigens that are coming down the line with Versamune. So thanks to everyone for the opportunity to just share with you about this platform. And I'm happy to be part of any additional questions. Thanks again.
Lauren, again, a great presentation. You've made some quite technical information easy to consume. For those not familiar, I'm actually here representing a survivor. It's 4 years now this week since I actually started treatment. So having gone through it and seeing cisplatin up there, that was one of the chemotherapies that I actually went through. One thing I would like to put to you, Lauren, because this does contain survivors, so the language used is not always common. You talked about the benefit, the reduction in toxicity. Do you want to actually explain what that means to a patient?
Okay. Thanks so much for that question, Ben, and congratulations on 4 years. Happy anniversary, and may the start of your 5th year be your best ever. One of the things that we know is that in advanced stages of disease, one treatment intervention is not going to get it. One chemotherapy agent, just radiation therapy, just a single immunotherapy agent, even if they're very, very, very powerful, one agent is not going to get the job done once you have tumor that is spread to other areas of the body and that's fairly far advanced. So we know that we can get more tumor killing when we combine different therapies. The problem is when you combine more anti-tumor therapies, you get, in addition to enhanced tumor killing, you also tend to get more side effects. So it's really important to try and strike a balance between having a combination that gives you great anti-tumor activity, but if it makes you so sick and it gives you so many side effects that your quality of life is completely trashed, it makes it very, very hard to tolerate that combination therapy. So the goal is to give combination therapies that we've really got a good rationale for. You know, if we've got some understanding, everybody knows that of mice and men, clearly men are not mice, and we've cured tumors in a lot of mice. But if we have some at least good evidence that agents might work together and then also be well tolerated, that is going to help us give and get a greater anti-tumor bang for the buck without the trade-off of increasing toxicity. That's the reason why we think that we're very excited about PDS0101 and Versamune-based combinations, because the adverse event profile is consistent with a vaccine. Okay. Local injection site reactions, a little bit of arm soreness. Sometimes people might feel a little bit fatigued or malaise. Nobody's had any allergic reactions to any Versamune-based products to date. But those local injection site reactions are very well tolerated. And so we get additional anti-tumor effects, but by adding this to the combination, we don't increase the toxicity. And if you don't increase the toxicity of a combination, then you increase its tolerability. So it's about having a therapy that gets you more, gives you more, but doesn't trash your quality of life.
And what would you say your driving force is for this? Is it something that improves the quality of life, or is it something that destroys the cancer quicker?
Well, I'll take your question in the 2 parts that you gave. I do think there is the potential to improve the quality of life by improving the tolerability of combination treatments. Okay. So I think there's definitely that significant potential there. The other issue is you said, is it that it actually kills the tumor quicker? Well, one of the things that's really, really important, I think, for people to understand in general is chemotherapy is like dropping a nuclear bomb. You know, there is going to be kill. There's going to be kill of the tumor cells, but because it's a bomb, there's also going to be bystander effect where you get kill of innocent, healthy, normal bystander cells, and you get the side effects.
Is huge, yeah.
Yeah, associated with chemotherapy. Ditto for radiation therapy. Okay, it's like it's not an atomic bomb, it's an electron neutron bomb, proton bomb. Okay, where the radiation again is destroying and attacking that tumor tissue, but you also get that bystander kill. When you're delivering immune therapies, whether it's a checkpoint inhibitor taking the brakes off the immune system, or a therapeutic cancer vaccine like PDS0101, things have a different rate of response. Sometimes you don't initially see dramatic shrinkage of tumor. You can see it, but it often happens at a little bit slower pace. Instead of dropping and shrinking tumor immediately, it actually takes a while, because what are you doing? You're taking the brakes off the immune system, so the T cells that are there kind of have to wake up and go, oh, wow, we can now go into the tumor. If you're giving a cancer vaccine, you got to train the army. So just like there's basic training and it takes some time, basic training is the same way for arming the T cells to then go in and track the tumor. And actually, in the very early days of immunotherapy, a lot of people did not believe that things were kind of working, because one of the things that we typically look for in clinical trials is the first signal is progression-free survival. And then we also look at the highest standard, which is overall survival. And sometimes in the first 6 months, there was really no difference between people who were getting a checkpoint inhibitor or, a placebo. The progression-free survival was about the same. Sometimes maybe even a little worse for the checkpoint inhibitors or whatever the immune-based therapy was. But
it'd be fair to
after
say
about
that
6
the
months,
benefit is that it's reducing the toxicity, so it's reducing the side effects. And so a side effect of your approach is improving the quality of life.
absolutely. Yes.
Brilliant. No, thank you. Thank you for that.
Yes. Mm-hmm.
Right, well, thank you very much. I'd like to move on to the questions. We have I'd say about a half hour. We have several really good questions, some of which were ones I had written down even before. I'd ask our panelists to keep the answers relatively succinct. We can always get to other things later on. So let me jump down to have a whole list of questions in front of us here. One of the most, several people have asked this question. When potentially are we going to see some of these therapies as first-line therapy, either alone, which seems unlikely, or in combination with radiation therapy? So instead of the typical chemo radiation that we see, when we think surgery is not necessary, or surgery and radiation, when can we potentially see these? So Ali, let me go to you next. Your thoughts on that, and then Dr. Wood, of course.
Lauren is probably better suited to answer that. My feeling is that we are gathering evidence and we are learning more and more, and the momentum is shifting towards these new interventions, and the case is getting stronger and stronger. So I think it's a matter of time that we actually will see these as first line options, and not as an afterthought that we've tried other things and they haven't worked and the cancer is still growing, and then go to these drugs. That's my feeling. I'm not sure whether Lauren agrees or not.
Oh, I absolutely agree. And as an immunologist, one of the things that we know is that we always want to try and deliver our therapies earlier on in disease, when the disease is more localized and it hasn't spread. And so while we are starting our initial studies in patients with advanced recurrent cancers, just because that's kind of where the area is of greatest unmet medical need, we have a very great interest in terms of moving up the delivery of PDS-0101 in what's called the early treatment setting, even delivering this therapy before people go to their initial transrobotic surgical resection of their tumor, to deliver the therapy before they go get their resection, to see what kind of anti-tumor effects that it has, whether or not it shrinks the tumor, and then actually whether or not it delays the tumor from coming back. So earlier is better. That's what everyone agrees. It's just that when we kind of start for the first time in cancer patients, we kind of want to see if there's any evidence of a signal in the patients that need it the most.
Great, thank you. One question a little more specific, and I do want to get to one question live, but if a patient has CPS 80 with PD-L1 expression, treatment with only pembrolizumab would be palliative or curative? So kind of a specific question, Dr. Wood.
So
Arthur, sorry, ever so quickly, we've got a lot of people here that aren't clinicians. What does that question actually mean before we even start looking at what the
Right,
answer
so
is?
I'm going to ask, and actually maybe I'll ask Dr. Khurram first, because he covered the topic. So just to explain the question, Yes, thank you. And then Dr. Wood, and both of you can chime in on the answer.
Right.
So Ben, if you remember from my presentation, I was telling you about immunotherapy, that we calculate this combined positive score in the tissue to determine whether a patient is suitable to receive immunotherapy or how likely they are to respond to immunotherapy. And I showed you the examples of if the score is less than 1, that they're not suitable. If it's greater than 1, then they can receive it, and greater than 20 are much more likely to have more benefit. So 80 is a very high score, as indicated in the question, and then they are asking whether the immunotherapy that we're going to use is going to be palliative or curative. Curative as in we're trying to cure the cancer and get rid of the cancer, and palliative as in trying to make things comfortable and reduce the symptoms. And my feeling is that the CPS score will not determine whether it's palliative or curative. And it will be the other factors like the tumor stage and the size of the tumor and the anatomical structures that are involved, and whether it can be either surgically removed. If not surgically removed, of course, what are the other factors? The patient medically fit enough to receive the treatments? Have they got any other underlying conditions, etc., that are more likely to determine whether the treatment is going to be curative or palliative? Is that correct, Laura?
Oh, absolutely. And so what I would just add onto your description in terms of the other factors that would impact the outcomes, the other important thing that I've highlighted is with a checkpoint inhibitor, in addition to the size of the tumor, the anatomic location, prior treatment that the patient may have had, is also, even if we take the brakes off the immune system, the real question is whether or not the immune system also has been able to mount a response to attack the T cells, the tumor. We can take the brakes off with checkpoint inhibitors like pembrolizumab, but if there aren't T cells that recognize the tumor and then can go and attack it, even if you unmask it, then you don't kind of have the desired outcomes that we would like.
Great, thank you. I'm going to try something here. Peter Russell has a question, and I'm going to hit answer live and see how this works. Does that sound all right to everyone? Let's give it a shot.
Sounds great.
Doesn't really do anything other than you actually just talking about it.
Not anything. So I'm going to read it. All right, bit of a complex question. My HPV positive cancer was detected in a lymph node. Spent 18 plus months chasing it. It had been suggested that my immune system was effectively dealing with it, but potentially overcome by tumor on occasions. Eventually, the primary was found in the tongue. It was small, was biopsied. Some was left in place. Surgery to remove it 6 weeks later found no evidence of the cancer. In between, I had 2 doses of Pfizer COVID vaccine. May this have kickstarted my immune system to fight the cancer and resulted in the immune system dealing with the tumor? So, interesting question. I'm gathering from the question that there was not any radiation therapy. Hopefully that I am correct about that. So in any event, let's see, who should we go to? Well, Dr. Wood.
Well, it's a really interesting question, and it's a really excellent question that a lot of patients have. The first thing is in theory, the COVID-19 vaccine is training your immune system to recognize pieces of the SARS-CoV-2 virus. Boom. It is a virus. To our knowledge, there really is not any cross-reactivity specifically between SARS-CoV-2 and HPV-16. Sometimes when you get a vaccine, your immune system can be stimulated, and it not only kills the target it's intended to kill or prevents you from being infected with that particular virus, as in the case of the COVID-19 vaccines, but the immune response also recognizes tissues or other cells that may have a little piece of that. To my knowledge, there's no evidence of cross-reactivity of immune responses between SARS-CoV-2 and HPV-16. However, they're both viruses. The greater question of whether or not just revving up your immune system while you're receiving a regular prophylactic vaccine like COVID vaccine or flu vaccine, and whether or not that may enhance your immune response to your tumor is a really good question, but the honest answer is we really don't know. There's some evidence that people who have gotten BCG vaccine seem to have less severe COVID-19 disease. And BCG is basically a vaccine that's used in many resource-challenged nations to prevent TB. And it's a bacteria. But somehow people who get COVID seem to deal better with it if they've already had BCG. So you can see this kind of general revving up of the immune system and some unanticipated benefits. But to my knowledge, I'm not really aware that COVID-19 vaccines have been shown to specifically rev up the immune system and help people fight off their cancer. Clearly, there's no worsening of cancers. And clearly, patients with cancer generally need multiple doses of the COVID vaccine because they tend to be immunosuppressed.
Dr. Khurram, any additions to that?
No, really. I think Lauren has pretty much covered everything. Yeah, I don't think there's any evidence yet, but there's some evidence to suggest that other vaccinations may help. But yeah, I don't think there's any direct correlation that we are aware of.
Great, thanks. In the moment, we're going to go to a live question. I was just reminded of one thing really quickly. You know, it's interesting that what Dr. Wood and Dr. Khurram have talked about today is something that's evolved over a long time. So it sounds like Dr. Wood and I went to medical school at the same time. And when I was at the Dana-Farber Cancer Institute, there was a gentleman named Tim Ebelarn who was doing a lot of work with melanoma. Melanoma is one of the tumors that really showed us that somebody's immune system can actually cause spontaneous resolution of the tumor. And Dr. Ebelarn was growing T cells out of culture way back in the 1990s to try to make a vaccine. So, what we're seeing today with the work that Dr. Wood is doing, is sort of, I'm sure Tim would be very excited to see that. And so this is something that has evolved over time. And, it also shows, unfortunately, how long it takes to be able to get to this point. And we talked about photodynamic therapy before. We were talking about that when I was in residency, and it still has been difficult in terms of a delivery system that will deliver over the entire anatomy in the head and neck, just because of the nature of it. So we are going to try to go to Suzanne and Nick. I'm going to ask Tom to take care of that. They actually have two questions. And I'll put them out there anyway in case we have technology problems here. Why is treatment with Keytruda for recurrent squamous cell carcinoma applied for 2 years maximum? And then they were also wondering if there were any trials in England or Wales for triple combination for recurrent HPV positive squamous cell cancer. So in any event, Tom, if you can try to kick things off here to give us some live questions.
We should be live. Suzanne and Nick, can you try and ask your question?
Yes, as Arthur said, we're interested to know really. I've been undergoing the Keytruda drug now for 12 months, approximately. It is helping. I have an HPV positive base of tongue tumor. It appears to have, it's certainly stopped growing. It's sort of stayed pretty much the same. If anything, it might have slightly shrunk. So that's after 12 months. I have had a few adverse effects, mild, I would say. I do have a long history of systemic lupus. So I tend to have a bit of an immune system that works a bit too well sometimes. And, that obviously comes with problems. However, listening to this morning, listening to what you've been talking about, I'm very interested to know a little bit more about how that might progress. And indeed, you spoke about naive patients versus patients who've already undergone some PD-L1 inhibitors. how would that pan out? I mean, essentially, you know, if this were to sort of stop being effective, or indeed, would it be in my interest to look elsewhere and find something which offers the PD-L1 plus other combinations of oncolytic virus, etc.?
So, Arthur, do you want me to take that question, or do you want to take it, or?
No, I'm going to ask you to take it, Lauren.
Okay. At Suzanne, I'm thrilled to hear that you are tolerating your pembrolizumab and that you've had 12 months of therapy. Arthur had mentioned that you had also said, well, why do we only give it for up to 2 years? And that's basically because from the studies of Keytruda, in essence, there wasn't much benefit seen beyond 2 years of therapy. And so that's the reason why we stop at 2 years. Generally, it's 35 cycles. The fact that you are able to tolerate it and you've been tolerating it well with just a few side effects is very, very important. I just want to highlight for other patients that may be listening to the call, Suzanne said that she knows that she has lupus, which is actually an autoimmune disease. And I just want to highlight the fact that we know that one of the side effects of these checkpoint inhibitors is they can actually cause autoimmune disease in patients. Autoimmune disease just means that, like Suzanne said, your immune system is a little bit overreactive and it attacks some of your own normal tissues. So when you see Keytruda or Opdivo, patients who receive these checkpoint inhibitors, oftentimes one of the side effects is autoimmune disease, sometimes affecting the thyroid, sometimes affecting the lungs, sometimes affecting the intestines. So you get inflammatory bowel disease, different conditions that can be successfully managed. So it's been terrific, Suzanne, that you've been able to tolerate the pembrolizumab, and importantly, that your lupus has not gotten dramatically worse. To the other part of your question, if you were to have evidence of progression, meaning that your stable tumor actually starts to expand and grow, or a new area of tumor appears, then yes, I would strongly encourage you to seek potentially an investigational trial with a combination therapy. Particularly a trial that's designed to look at patients who have progressed or failed checkpoint inhibitors, which is what we call checkpoint refractory. I would want you to get a combination, ideally, that helps your immune system also target HPV-16. And as you mentioned, there are investigational oncolytic viral therapies where we give viruses. Sometimes they're live, sometimes they're inactivated, but the viruses carry those antigen proteins from HPV-16. And because the virus is delivered either into the tumor or into the body, then the virus is taken up by cells of the immune system, and then the HPV proteins in the virus then stimulate the immune system to attack the tumor. So I would recommend a combination therapy regimen that you would pursue. But it's not necessary as long as your tumor is not growing. I think another important takeaway message for all patients is sometimes we're not able to dramatically shrink the tumors. But if we just stop them from growing, that can contribute to patients having still a very significant quality of life and prolonged life.
Thank you.
Great.
I've just
Dr. Khurram,
posted the
anything to
link
add?
for a clinical trial that's going on. It's called Compare. Suzanne and Nick in the Q&A window, so you might want to look at that.
Sorry, I didn't catch what you gave a name. I didn't get that.
Yeah, I've just pasted a link in response to your question in the Q&A window, so it might be worth having a look at that.
Thank you. Thank you. Thank you to both of you.
Welcome.
Ali,
I think-
I'd quite like to pick up on a
Oh, go
point
ahead,
you made.
Ben.
Yeah, sorry, Arthur, I didn't mean to talk over you.
No,
I
that's
just want
okay.
to pick up on a point you made a moment ago, that some vaccines have been shown to actually help promote the immune system to defend against cancer. That's not something I've heard of before. I mean, it was interesting to hear about the BCG comment, but what else is actually going to help specifically with head and neck cancer?
Well, Ben, I would say that, the data is not hard and fast as it relates to one specific vaccine associated with better responses in patients who are resisting cancer. Okay. I think that there have been observations in some population studies of cancer patients that suggest that when patients receive vaccines and their immune systems get stimulated, they may be better able to attack their cancers. On the other hand, it may actually be an association that's true, and totally unrelated. And how it could be true, and totally unrelated is that a patient who's resisting cancer, if they're able to respond to different types of vaccines to prevent flu or COVID or other things, that means that their immune system is actually better able to respond. And maybe their better ability to fight off their tumors is not really due to the vaccines they got, but just the fact that they've got an immune system that seems to be better able to respond in whatever circumstance it needs to.
So no conducive evidence to actually point either way at the moment.
Yeah.
Okay, that's brilliant. Thank you.
Ali, any other insights? Or
No,
Arthur?
really, no. You're absolutely right. I think there's some circumstantial evidence, but no hard and sort of true facts. There's a question from YouTube actually, for you, Lauren, which says, when is the phase 2 trial for HPV-related cancers expected to be finished after recruitment is complete in Q1 of 2022? And when is the top line data expected?
That's a great question. Everyone is very interested. And so as was posed in the question, we anticipate that recruitment to the trial will be completed in the first quarter of next year. It's accruing a total of 56 patients. And our understanding is that the NCI is planning on presenting more mature data at the 2022 ASCO meeting. It's really important because this trial miraculously actually was able to get launched in the middle of COVID in the US on time in June of last year. And so there will be almost 2 years worth of mature data on a large percentage of the patients enrolled in the study. So we anticipate seeing that late in the first half of the year or early in the second half of the year in terms of the more mature data on the trial. As with anything, we always love encouraging promising results, but we really have to see how they hold up over time. And that gives us the insight in terms of, how well the therapy is tolerated, how well is it working, and how long a response is lasting. We really want responses that are potent, but we also want responses that are durable.
Great,
So the
thanks.
questions seem to be coming your way. I think someone else has posted a question in the comment window. Hadika Raza, and she's saying, do you think a combination of a cancer vaccine with cytokines such as interleukin 7, 5, and 21 can be an effective approach because they can increase the capacity of antigen-experienced T cells?
That's a great question, and it sounds like somebody who's an undercover immunologist or a patient, that really is deep into the literature. So that's
she's a budding researcher.
A budding researcher. That's wonderful. We love new minds in science. So that's a really important and excellent question. Let's just give a little bit of background so that people understand. Cytokines are immune system proteins that are messengers. They're released by immune system cells to talk to other cells. Basically, the cytokines call the play for the immune system response, okay? There are, 200 plus cytokines. We discover new ones every day, just like we discover new types of cells of the immune system. And the two that were mentioned by Ali in the question, one is IL-7, which stands for interleukin-7, and it's known to really expand and promote T cells, particularly after people have received chemotherapy and the level of T cells in the body drops low. The body naturally produces more levels of IL-7 to increase individuals' T cells back up. So that's a great idea in terms of potentially delivering some tumor antigens with IL-7 and potentially some other cytokines, so that when they're delivered to the immune system has kind of like a supercharger booster cytokine with it. That approach is being taken by academic researchers as well as other companies to actually include some cytokines. Now, I'm not aware that IL-7 has been used, but they have used the tumor targeting cytokine IL-12, which is known to basically help attract the T cells to tumors. So that is definitely a possibility worth exploring for sure.
Great. Thanks, Dr. Wood. One question that was posed to me was, and in fact, first of all, Dr. Khurram mentioned the COMPARE study. I did put that link in the chat. You probably have to scroll up a little bit to find that. There was a question in terms of, are there sites in the UK, doing any of these type of trials, and what would be available? So I think to some extent the COMPARE study may be one. Dr. Khurram, any other thoughts regarding that?
Yeah, I was just having a look in to see if there's any other active trials going on, but I know some other recent trials have closed, but HPV related, I think this is the one that I know is actually recruiting right now in the UK. And it's a multi-center trial, so you can ask your local hospital, and they can take patients from anywhere in the UK. It's being led by Professor Mahana, who's an academic ENT surgeon in Birmingham. And they're looking at different types of treatments for pharyngeal cancer.
So I want to make sure we finish a little bit early to keep things on track, but we still have a little bit of time. I have a question that I'm sure many of the people here can relate to. We constantly look at trying to reduce toxicity from radiation therapy. There's a lot of hope that HPV positivity is going to mean less radiation therapy. Some people feel that in fact, many, the greatest side effects of radiation therapy happen from that last week. And if you can certainly reduce the amount of radiation, is there any thought that, these type of treatments we've talked about today might be able to somehow, I think you mentioned this, Dr. Wood, shrink the tumor enough, whether it's given up front, as we do some of the neoadjuvant chemo at the Dana-Farber, for instance, where chemo is given up front followed by radiation. Is there any thought that this might be able to reduce the amount of radiation and therefore the toxicity? And I ask both of you to comment on that.
That's a great question, Arthur, and that is certainly the hope. That radiation toxicity is the reason why a lot of academic centers here in the U.S. have done de-escalation trials specifically for HPV-16 related cancer, because it's like we know generally HPV-16 is associated with better clinical outcomes. When it recurs, it's just as devastating as head and neck cancer with traditional risk factors. And so there's been the exploration of de-escalation of radiation. But our hope would be is that if we can deliver and help train the immune system to start attacking the tumor before a patient goes to surgery, that we might actually be able to shrink the tumor significantly, okay, resulting in what we call pathologic downstaging. That's a fancy medical name for saying that if you've got a large tumor, it's going to be harder to take out at the time of surgery. All right. They may not be able to get all of the tumor. It may also have spread to the lymph nodes and so forth. So sometimes what we do is we give treatment before that initial surgical intervention, which Arthur highlighted is what we call neoadjuvant treatment. It's before that first thing that we're designed to try and cure the tumor. And the hope is that by training the immune system, either with PDS0101 or Keytruda has actually been studied in the neoadjuvant setting and shown to cause some shrinkage of tumors, some evidence that the tumor is being attacked and destroyed. And I'll let Ali kind of get into an explanation maybe of pathologic response that we look for. But that is the hope, that that earlier treatment would then result in downstaging when the surgeon actually does the surgery, and then warrant maybe reduction in the necessary radiation therapy.
Yeah, I would agree, because although we've tried to de-escalate things, I think sometimes with HPV cancers, the late effects can be distant metastases, or when it comes back, it can be equally bad, similar to conventional head and neck cancer. And it's just finding the sort of new targets, new molecules, like Lauren said, retraining your immune system and reprogramming it to deal with the problem better the first time. Things are getting better. They're significantly better. I mean, you guys referred to 1980s when you were training, and I trained in 1990s. Even compared to then, it's significantly changed. I mean, I didn't even hear the word immunotherapy. It's quite recent, isn't it, in head and neck cancer? So things are changing at a very, very rapid pace, and the hope is that we will get things better for head and neck cancer patients. Yes. And the treatment response, I think, is interesting, because right now for head and neck cancers, we give the checkpoint inhibitors to people who got recurrent or metastatic disease, and not to everyone. But that's what's been shown in the trials and the big studies that have been done so far. But hopefully with the work that Lauren is doing and other groups are doing, the more evidence will emerge at early stage intervention, and hopefully stopping the cancers from getting to that stage. There are other people at earlier stages. I mean, Lauren, you're probably aware of it, looking at sort of the, we spoke about viruses and gene therapies, but also combining them with sort of magnetic nanoparticles. So actually, the treatment can be directed using things like MRI machines, which have got giant magnets and specifically target cancer cells, and just make sure that you protect all the normal cells surrounding them. But they are all quite in the early stage. But hopefully in 10 years, when we are having this same meeting, hopefully face to face, we'll be talking about some of those treatments.
Right. Maybe you want to just explain to people what magnetic nanoparticles are, and then how they interact with the MRI.
So basically, just like your medicine will be mixed with, I would say, tiny little capsules that you can't see with the naked eye. Okay, so you can see them, maybe not even in the microscope, but you saw those special images that Lauren showed under the electron microscope, the tiny little particles that are magnetic. So they go along with your drug, or are coated with your drug, and they're delivered directly into the tumor. Okay, so that means when you actually have your MRI scan, the MRI does not have any radiation. It uses these magnetic fields to actually generate these images. So because it's already got those magnetic fields surrounding the patient, if you lay in the MRI machine, you can use those giant magnets to actually target or create a magnetic field to focus on those areas where those little nanoparticles or little capsules are. That are actually small magnets, tiny magnets, invisible magnets sitting within the tumor. And hopefully they can kill the cancer from within. They take over the cancer machinery, just reprogram it and kill it from inside.
That's exciting.
I have really exciting.
I have one final question here. We have limited time. I'm going to ask for a 30-second answer from each of you regarding this. And the question is this: would you give immunotherapy to a patient who didn't have cancer? The patient had breast cancer, now believes they're having immunotherapy for belt and braces, which I think in Lauren and my language would be belt and suspenders. I think. Go with that. I have to admit, Dr. Wood and I have really had to put up with a lot of accents today. We have perfect speech, of course, perfect English, you can tell. But anyway, quick answer on that one: the belt and braces.
If the patient doesn't have evidence of cancer at all, I would not give immunotherapy. And the reason is these are very potent drugs, but the side effects are very significant. They can be. And the autoimmune disease affecting your thyroid, other organ systems can be significant. So when you talk about risk benefit, there's more risk and there's no need for a benefit because there's no cancer. So no.
And I agree with that. I don't think there's any indication or need to do that. Of course, side effects are one thing, but cost is also another thing. So in the UK, you won't be able to get it anyway. And you're thinking about the US, one vial of this medicine costs about £2,700. So you're basically just throwing your money down the sink, really, for not much benefit. I mean, we don't even recommend using it for pre-cancers and dysplasia. So a belt and braces approach wouldn't be ideal.
Yeah,
I'm totally in agreement as well. At the limited time, Ben, I'm going to turn it over to you as a survivor. Quick thoughts on everything you've heard.
I just think it's a shame that everything's taking so slow to actually come out and support those that are struggling. The technologies that we're hearing about today, absolutely outstanding. It seems as though we're really working towards reducing the risk for the patient, which is thereby improving a quality of life. And it'll just be good to see that come sooner, because quality of life obviously is key once you've got over cancer.
Well,
that's brilliant. Thank you very much indeed.
Arthur, can I just say something?
Yes, sir.
And this goes to obviously David, to Lauren, and yourself, Arthur. When we had COVID suddenly hit us worldwide, globally, how come we got a vaccine out, developed through NICE, through all the organizations, through everything, and then put in people's arms within 6 to 7 months, even shorter, I would say, and now being used worldwide with no data, no previous trials, no nothing, yet we got it so quick. So if we can do it that way, why can't we do it for drugs for cancer?
I have a quick answer on that. And it's ironic you asked this. I just was writing a paper last night because I'm actually taking classes, believe it or not. And this very question came up. And what was posed was the fact that a lot of the experience was already there from mRNA, vaccinations, viruses that were where we targeted mRNA. So a lot of the information was already there, a lot of the background information. This was not starting from scratch. Going after the coronavirus was really based on a lot of existing material. So it allowed people to create the vaccine very quickly based on that previous technology. So a lot of the testing was already done. A lot of the information about how these vaccinations work was already done. And so a lot of the speed with this was really on the production of it. It's not that it was, there were no corners cut in terms of testing or anything like that, at least in my I think, Dr. Wood, this is kind of in your wheelhouse. So maybe a quick one on that. Does that sound reasonable?
It absolutely does. And the whole point is that it was the vaccines were generated with incredible speed. But as Arthur said, there was 10 to 15 years of tons of companies slamming away unsuccessfully at using mRNA technology to generate those protein antigens for SARS-CoV-2 that resulted in a vaccine. The great thing is that now that the success of the mRNA technology has been demonstrated with COVID vaccine, companies like BioNTech as well as Moderna are now actually developing mRNA cancer vaccine products or cancer therapies and trying to leverage the rapid ability to just identify an antigen, whether it's from a tumor cell or a virus, get the sequence, and then make the mRNA and boom, very quickly scale up a new product. So that question is a great one, Chris. And I would actually say it's probably one of the greatest maybe scientific benefits and blessings that have come out of COVID, as devastating as it's been, is there is a new differentiating technology platform that allows things to be made very, very quickly, no cutting of corners, but just the time that it takes to actually make the product. That takes a lot.
But I understand that, but I still come back to you on the fact that, you know, we haven't only started this year on new drugs for the battle against head and neck cancer. We've been doing them for years.
Yeah.
I know BMS has been doing it, Merck's been doing it. They've all been doing it. So everyone's been battling to bring out a drug. It's not brand new.
Right.
So if you take the concept of what you said, surely if you've got all those pharmaceutical companies in one big room and put all their brains together, surely we could get one drug out the other end very, very quickly that would do it. Or is it because each individual pharmaceutical company wants to do it themselves to be the leader, and then that way they take the lion's share of the money? That's from a patient's perspective looking in.
It's difficult to comment on the pharmaceutical side. I think
there's a bit of that competition, but there's also, I think in terms of cancer, probably the drive and incentive wasn't as much. There's the market. Once you make the vaccine and how many patients or people will use it, so the appeal is not as much in terms of how widely it will be used. So maybe the incentive and drive isn't there for people to work together and deliver so quickly on this. And on top of that, we know how head and neck cancer always just gets neglected and doesn't get the same attention as some of the other cancers. So it's one of those cancers that just, it's like an orphan, unfortunately. People just don't care as much as breast cancer or lung cancer.
I think it's, you know, I mean, there's that side. I think it's important that, you know, we go around, first of all, why research is as it is. It's important that we don't harm people in our unending attempt to make people's lives better in terms of quality and survival. So there are a lot of hoops, and I can see that from the outside. I'm sure patients are desperate to find better things, but we have to do it the right way, because there are unseen problems if we don't follow the research pathway. But you're right, Chris, things have been shown that we can speed them up in certain ways, but time, certainly in time of trial, will go on. But, you know, it'll get better, it'll get smoother. But, you know, there will be delays from idea and good ideas to them being available for use.
So I'm going to ask one more question, and this isn't to Dr. Lauren or Arthur. It's Dan, addressed to Ali and David, because both of you are sat in hospitals. Maybe not at the moment, David, because you're in your shed. And I don't know where Ali is, so at this time in the morning. But, you know, Lauren's company has been trying to get into the UK for 12 months, and that's how I got in touch with them, because they were struggling to get through doors of hospitals to take their trial on. What stops hospitals taking a trial on from a patient? Because what they've got seems to be great, but unless we get trials here in the UK, the rest of the world will get that drug. The rest of the world will get that combination. It'll all go around the world, but poor old UK and head and neck is going to stay static. So I just want to know, I know you're looking at it, Ali, through, because I made the contact with them, but what generally stops a hospital doing it? Is it money? Is it finance? What is it that stops them?
Do you want to go first, Ali?
Up to you if you want to go first.
Okay, so there's a number of things will stop a hospital taking on a trial. First is that it'll need to go through the national and probably local ethics bodies to see, does it fit with the desires that we have as an agency? And then, are we capable of performing this trial? Do we have the resources to achieve it? And is there any financial incentive to do it on the other side? And they're quite important things for an organization. But I think that if there's a trial available, there is a national data source, and you know, all health boards are able to take on trials if it fits their criteria. But I guess that's it. It's logistics and financing. Is that fair?
Yeah, I think most of this is logistics and financing. There's a little bit of sort of willingness as well, but I think we should find the right people. So as soon as you mentioned it to me, I pass it on to my oncologist, and they know that I never email them unless it's something useful or important. And hopefully we'll get Sheffield as one of the sites on this. But also a lot of the hospitals are already inundated with a lot of demands for other trials. So there's a long list. So it's very difficult to bypass those earlier requests. So you just have sort of a queuing system, unfortunately. And sometimes they say, but we already got 15 other requests. And we've signed up, for example, compare trial and this trial and that trial. So we may not have enough patients to actually contribute to this study. And because of COVID, there's been no recruitment in the last year or 18 months. Again, that's created a big sort of bottleneck and backlog of things as well. So that's caused a further delay. But generally, there is a willingness if you can just sort of cut through the initial sort of people and find the right context, and people will be willing to help and sort things out. But yeah, at the top level, if you just approach the trust, like I mean, David said, there's a lot of paperwork and things that need to be sorted before you can get anywhere.
Yeah,
Perhaps we can chat after this.
That's the beauty of being a National Health Service, because you know we share everything, don't we? But anyway, I'll move on.
Anyway,
Yeah.
I'd like to thank everyone. Our panelists were great. This is a great topic, great way to start the day. I want to thank the Swallows for inviting all of us, including myself, of course, to run this. And the awareness of head and neck cancer, Ali mentioned the fact that we're kind of like an orphan when it comes to head and neck cancer. It's just not as popular. But I think what the Swallows does is really gets it out there. And, there's this small team in the northwest of England, of the UK, called Manchester United. Perhaps you've heard of them. And, they're worldwide known. So, I mean, we can get, head and neck cancer awareness out there as well. Chris, I see that big smile on your face. So thank you all and have a wonderful day.